We have some time for questions before the bar opens at 1700. With regard to tumors, I'm glad someone else likes to do that kind of stuff. Pretty sobering. Any questions on any of the topics this afternoon? They are stunned or they're comatose.
No, they're
Or they
tired.
want the
They've been
bar
here
to
for
open.
12 hours. Well, having none, Mara, would you agree? Send the guys to Pedro's going to talk.
Sorry, I have to ask a tumor question. We see a lot of fibromas in kids, tons of them, and they're very, very, well, they can be quite malignant. My question is about Carney's syndrome. Pretty rare, and you see these myxomas that sometimes get resected by somebody and then they come back. They get resected again, they come back. They can be on the left side, they can be multiple. What's your approach to these patients?
Carney syndrome and recurrent myxosarcs or sarcoma. It's coming back like that, Pedro. I think it's probably a myxosarcoma.
Yeah, you know, I mean, they do come back. I've only ever seen two. One was Chris Feindel's patient. She came back a few years later. And the other one is one I had myself, and they saw a left-sided tumor, a left-sided myxoma, and I operated. And on the inside of the right atrium, there was another myxoma that I saw. And so what you have to do with them is surveillance. You know, the paper out of the Mayo Clinic said in the 50-year article, they found about 13 people that had recurrent myxoma up to about 27 years later. 3 of those 13 people were Carney's. You just have to follow them. And I don't know whether they should get an echo every 6 months. For sure they should get one every year. And I guess they just keep on going until we cut up their part many times. I don't know.
But you keep going after them, even if they're small, they'll grow. They'll keep growing.
You
I'm
know,
talking about left-sided.
Yeah, you know, I had a cardiac tumor conference. I run it every year. That was my only disclosure. Unfortunately, I don't have any financial disclosures. But I had one cardiac tumor conference about myxomas, and I wanted to ask them, what do you do? Even fibroblastomas, I can't get anybody to talk about fibroblastomas. On the right side, you can watch them, I guess, a little bit. They will grow, obviously. Yeah. Nobody knows how fast they grow because we always operate on them. So eventually, you'll have to take them out left or right-sided. There are different kinds of myxomas, and I don't know whether the Carneys always grow one type of myxoma, the villus type or not, but you know, they are embolic risk. I think the myxomas are much, much more an embolic risk than a fibroblastoma. I've never seen a part of a fibroblastoma. Every time I've resected a fibroblastoma from the left or right side, it's always been the full cauliflower, the whole thing. Whereas myxomas, you know, when you're taking them out, you have to worry that little bits and pieces of the villus type have fallen out. So I think if it's the ball type, you know, the solid type is one thing. They're going to obstruct. But the left-sided ones, especially if they're villus, you have to remove them. You just have to keep on going after these. We've only, for Chris Feindel's, we operated twice, I think, right, Chris, on that one. And my lady, she's only about 18 or so, and I saw the 2 myxomas at the same time, and I haven't seen any. She's about 3 or 4 years later. But I guess you just have to keep on going because they will either obstruct or embolize.
What do you do with the fibromas in the kids, Pedro? They keep coming back?
No, they don't.
No.
Well, first of all, it's a benign tumor. Most of the indications are VTAC.
Yeah.
Incessant VTAC is the most common indication. We see obstruction sometimes, and the other indication is usually mitral valve regurgitation from distortion. Those are tough because you have to take out the entire tumor debulk it as much as you can, and then the reconstruction often distorts the underlying architecture of the mitral. So those are hard, but we see massive fibromas. I mean, twice the size of the native heart that you can actually debulk, and you get rid of the VTAC. I mean, these kids can survive, and I've got pictures of kids 20 years out, and they're still doing fine. They don't grow back.
Wow.
Wow.
Yeah, they stay the same size, so that as a baby they look gigantic. And then I just took one out last week. They have to tell the parents this has been in their heart for their whole life, but they don't get bigger or smaller, the fibromas.
Well, I disagree. They do grow. I have seen them grow.
Oh, is that right?
Oh, yeah.
I guess I only see them in the adults. But
We've got about 50-some that we've done, but they do grow. So, yeah, the majority don't. You're right. I do agree, but I certainly have seen them grow and become obstructive.
Elizabeth Stevens from Mayo Clinic.
Well, Thank you for an excellent talk. I was just a comment on Carney syndrome. We had a referral, multiple redo, and it was advised, I think, based on at least one other paper. I can't recall the specific one, but taking out the entire atrial septum and then cryo the edges to try to decrease recurrence rate. But I don't know that that data is very strong, but at least as our group referred that was the recommendation. So.
I missed what you said.
Oh, sorry. If you have a Carney syndrome patient who comes with a recurrence, and as you know, they can come back in different spots, but if it's in the atrial septum, to take out that whole area of the atrial septum, and then I think there's some limited evidence that you can cryo the edges to decrease recurrence rate.
Yeah.
So-
The problem with that is it don't just get them in the heart, to get them everywhere. So
Yeah.
who knows what to do about them, but they appear in different places. Again, I only have the one with Chris Findell. Chris, stand up there because you're here, but is it
Eric, 1 second. This mic first?
Thank you for some excellent talks. Question for Dr. David. So I noticed you presented that in syndromic population, about 1 in 6 tend to have concomitant root pathology and mitral valve pathology, which seems right from my experience as well.
In syndromic
In syndromic.
ones, yeah.
But presumably this is due to connective tissue disorder, and presumably most of these patients are presenting at a young age. So my question is, have you noticed people who have only valve sparing done at the initial operation go on to develop mitral valve pathology downstream? Are there cases of that?
We do. We had 8 cases, but follow-up in the last paper. There'll be more now. We're going to be publishing a paper 30 years out to come, and the incidence has gone up. I think it's going to be about 8 or 10% of those patients come back from mitral valve repair, which is has given the opportunity to learn a new thing. As part of consent, I tell them, I'm going to explore the aortic valve. So I open the graph, take a look inside, and it's fascinating how it looks 20, 30 years later.
Including
Adaptation is a real thing in nature, you know. It's,
including the running 6.0 Gore-Tex on the free margin?
yeah, that's how we saw that, yeah.
And you've never seen it, Gore-Tex, you love Gore-Tex.
It disappears, the Gore-Tex.
But Urbine
So
and
one thing we
Laurent
learned.
will tell you that some Gore-Tex in some individuals is going to calcify given enough
Yeah,
time.
absolutely.
You've never seen it?
Well, I'm going to show tomorrow a video of 24 years later, a 16-year-old Marfans. I had to did the valve sparing. She came back some 6, 7 years ago with mitral regurgitation, repaired the mitral, took a photograph of the aortic, and the 3 Gore-Tex are using every cusp. Disappeared. You don't see anymore. They disappeared. It's there, but became embedded. But unlike Gebring, because Gebring took this technique from us here, Gebring run over the free margin. I don't think this is the right way to do Gebring. If you're going to use Gore-Tex, no, I'm serious. I think you should have the free margin and weave in and out the free margin. So the Gore-Tex is not a free margin, the cusp. I think it'd be part of the cusp, the body of the cusp. That's how we have always done.
In our experience in tricuspid valve and
Oh, no, it's
Gore-Tex,
good, no good.
we never saw a calcification of Gore-Tex, while in bicuspid valve repair, the Gore-Tex, all the patients calcify. And in bicuspid, so Gore-Tex for bicuspid is not good. For tricuspid, I agree that it's really very good.
Particularly for the syndromic one, the young people, they are 20-year-old, you want to save the valve. So we have expanded the indication of valve repair by doing this. So I don't think the incidence of the average population who develop aortic root aneurysm will develop mitral regurgitation like the syndromic. The syndromic is.
I just have a quick follow-up note. So, I noticed a lot more people in my practice with bicuspid aortic valve and associated mitral valve disease. Now, you you published a paper on anterior leaflet of the mitral valve being coincident with bicuspid aortic valve. What's your experience there?
We published that years ago. The mitral regurgitation in bicuspid aortic valve disease, almost invariably, is anterior leaflet prolapse. You're going to operate on them is a huge mass anterior leaflet, 35 millimeter, 40 millimeter, posterior, 5 millimeter only. So it's almost invariably, and I don't know if it's an annular dilatation first and then regurgitation, but it's a different pathology.
But is there any experience with repair of both valves in that
Yes,
context?
we have a bunch of Gore-Tex. And,
Eric Rosselli?
Yeah, thanks. If I could just make a couple comments, but I do have a couple questions as well. We recently published our series with benign tumors, 563 over 60 years, and we only had 2 recurrences. They were left atrial myxomas. I suspect there was probably a technical error there, and then like a Carney patient. Other comment, Juan-Pablo's case that he presented, that's my patient, and he misdescribed. I just want to make the point how great the homograft is for those complex reconstructions. When I opened that homograft, it was really beautiful homograft, had a nice piece of left atrium still attached to it. So we actually closed, he said something about Dacron, but there was no Dacron. We actually closed the dome with the homographed left atrial muscle that was attached to it. So it is still a really great tool for complex endocarditis, and I think we should continue to understand how to use that.
And that was very slick how you flipped it over and used the homograph anterior leaflet for the native recipient anterior leaflet.
Yeah, you got to make sure you're picking out a good homograft out of the bin, though.
But the bug, was it strep? It looked a lot worse than strep. Do you remember what the...
I don't remember,
organism
except I
was?
do remember the story really well about the guy babysitting his friend's raccoon, which is crazy.
But it's not Coxiella or
No,
Q fever. Or
no, it
any
was
weird
it
thing.
was some sort of weird strep variant. Tyrone, I have a question for you though. You were talking earlier today about the tricuspid valve, and I really enjoyed your presentation about the mitral valve and syndromic patients. What if we see a dilated right ventricle and a really big tricuspid annulus, and we're doing a reimplantation? Should we put a ring around those?
Yeah, we do, but we have a number of had tricuspid annuloplasty as well, but because they had this tricuspid regurgitation, not because the ends dilated. The leaflets are massive in those patients.
Their hearts are so big, yeah.
So it doesn't need. Mark, is Mark here? Mark, you get him off here. Mark has a paper about this when he was a resident at Hopkins 100 years ago. I don't know. Is Mark here? Mark published a paper they thought that even the mitral valve, if it was dilated, they should put a ring in both in tricuspid.
Yeah, it was the early 90s.
But it
Mark
was
did
a
that
small
paper
number,
when he was
30-some
in Cleveland.
Yeah. And Piroze, I have a quick question for you, if you can allow me to use the microphone again. Great, beautiful cases with commando procedure. Can you tell us a little more about when we have that patch and we're sort of reconstituting the fibrous trigone there? I've noticed sometimes you can get in trouble if you make it a little too short. Like, how do we think that through?
So,
Right?
you
Like
mean the double?
you know what I mean? After you get your patch, the dome closed, and you have that second bit of patch where you want to attach the aorta above the mitral. You can get in trouble if you don't make that long enough. You can get in trouble if you make it too long as well. Is there some sort of sweet spot?
So you treat it as just like you're doing a Manugian or a Nix procedure. You mean the non-coronary sinus part of the patch, right?
Yeah.
So you make it, you have the same, just like the way you do the Manugian procedure, you just bring it up onto the sides of the aorta. So you don't trim the patch right up front. Once you've finished the entire reconstruction of the intervalvular, like the mitral part of it, and then you tailor that patch to the aorta that is left behind.
Very good. Thanks.
Yeah, you have to be there and eyeball it. One more question, please.
I have a short question, Dr. Calciuso from Oslo. Thank you for the opportunity to come here. I have a question to Dr. Peterson. I was bothered about the pretty young guy of 38 years with a 3 travis and a calcified homograft. You said that you could do whatever. You could do a Bentel, you could do a Ross, and you did a homograft. Why did you do that? Because you know he's coming back?
Yeah, so what I meant to say is that once in redo root surgery, once you've defined the ring of the LVOT, not necessarily in that patient, what I meant to say, thank you for the clarification, is you can then do what you like. I mean, you can use the ring to implant a Ross, you can do if it's an older patient and you want to use a freestyle valve, a homograft. The reason I used a homograft in that guy is because he was on chronic, lifelong anti-suppressive therapy for fungus, and he also had intermittent Klebsiella bacteremia for which they had no source. So to do a redo Bentol, mechanical Bentol with prosthetic material, I felt had a high risk of reinfection. I considered doing a Ross procedure, but I felt I chickened out, so I just did a homograft, and recognizing that it will probably fail in another 10 or 15 years, and we'll have to do something else.
If he's lucky and alive.
Well, that's exactly right.
If you take a look at papers published in the 80s and the 90s when homographed, I was part of the group of surgeons who homograft as often as possible. Mark O'Brien, Barrett Boyce, and the group from Mayo Clinic published that, and Dr. Kirkland, when he moved to Birmingham, they published longitudinal outcomes of aortic valve homograft. The incidence of endocarditis in homograft is much lower than in tissue valve and even than mechanical valve. So it is, if the problem is continued exposure to bacteremia, like an IV drug user, I think a homograph is a good option.
Okay, thank you. Thank you so much.
Costa Peterson would certainly agree with you. Although he's retired now, for the addicts, he just loved the homographs and the redo homographs.
Yeah.
But the young man with the fungal prosthetic endocarditis, we all know his life expectancy is limited. Okay, that wraps it up for the first day of the Love Fest. Thank you all for being here.
Yeah, we're going to have a place to drink and eat as well, just drink. Downstairs at the Epoch, at the main entrance, at the end of the entrance, you're going to see the restaurant. There's a patio. We're gonna be
Guaranteed to
there.
have caipirinhas.
I'm sorry?
Caipirinhas.
See, I don't know if they have caipirinhas.